everyone, and good afternoon. And thanks for coming to listen to my talk. And I really enjoyed the talks in the morning. And maybe some of what I'm saying is actually fitting in quite well with what was said there earlier on. So I'm going to speak about autoantibody-mediated autoimmunity in severe fibromyalgia syndrome. And this is a little bit about my own background. I'm trained in anesthesia, so I'm an anesthesiologist. So this morning you heard from I think from a gastroenterologist and from a rheumatologist. So I'm a pain doctor and moved into the UK halfway through my training. I also trained in post-trauma immunology in the United States. And I'm now an associate professor at the University of Liverpool and a consultant at the Walton Center, where I see patients with fibromyalgia pretty much every clinical day. So this is a picture from our fibromyalgia guidance, which was published together an umbrella of the Royal College of Physicians in April, and which has proven really very popular. So we've had more than 10,000 downloads within the first 4 months. It's a multidisciplinary diagnostic guidance just about the diagnosis, and was led with many people together, including Dr. Chris Barker, a community pain specialist. And we've already heard that fibromyalgia is a syndrome, so there are a number of different things that people experience, and you will see in a moment why that is important also in the context of our research. We've tried to reproduce what people experience in the animals. This morning, you've also heard about the new WHO classification of chronic pains that essentially really classifies unexplained chronic pains. Fibromyalgia has its own part here. As under chronic widespread pain. You've heard from Winfried that not everyone is happy with that classification. Some might want to see, rather like to see it here. And thanks God, that's not, I don't have any need to be involved in that and make any decisions on that, but maybe there, certainly it will stay, I'm sure, under chronic primary pain as at least one diagnostic parents in the new ICD-11, which also means it can be coded much easier. And for many countries, that means it should get easier. I'm showing this slide because I have been involved in this condition, which is another subcategory, a rare one. Fibromyalgia is common, and this is a complex regional pain syndrome, which is a rare condition. And I've worked together with the ISP-SIG to formulate the diagnostic text for the new ICD-11. And I think we've done a great job, and we are really grateful from our perspective for this initiative that we can now, we've simplified the diagnosis, and we can make this diagnosis of CRPS much better than before. But all these conditions that we see here on this slide are characterized by pain that is longer than 3 months present, and not better explained by another diagnosis. In the terms of fibromyalgia, it's clear, we said it's not a diagnosis of exclusion, so that doesn't mean it's a diagnosis of exclusion. And they are associated with significant emotional distress and or significant functional disability. That's in the definition. So these pains are by far the leading cause of life years lived with disability worldwide. By far, chronic back pain is already the leading cause together with dementias. And then you have seen how many other chronic pain conditions are there. And we don't understand why people get this. Now, before I come to our research, I wanted to also touch on the nociplastic pain term, classically we've defined pain by its mechanism as either nociceptive, like in rheumatoid arthritis, where you have inflammation in the joints, and then the proper receptors on the nerves, the little detectors that every of our nerves have to detect damage, get activated, and that's called nociceptive pain. And there's no neuropathic pain as well, where nerves get damaged, for example, by disc prolapse or by in carpal tunnel syndrome. So something presses on the nerves and that causes a special type of pain. And in the past, we tried to desperately fit all these primary chronic pains into one of these two categories. But now we've got this new category termed nociplastic pain. And the idea here is that this applies when pain is presumed to arise from abnormal function of the pain processing nervous system itself. So neither is there any inflammatory focus, nor is there any pressure on nerve. There's something wrong with the nervous system. The nervous system doesn't function in the way it should. In the UK, interestingly, people use this as a synonym, use it synonymously with something with the brain, but that's not how it's meant to be. And I've asked if Kosek could let the group to please clarify that, if only for the UK, because it is meant to be the nervous system, not the central nervous system. It's either central or peripheral nervous system that don't function in the way they should and seemingly augment nervous signals. But we don't know what causes this dysfunction. So my own journey started in the 1990s when I was a junior doctor, and I was in a really interesting pain clinic in Würzburg, Germany, and they had already thought, well, maybe chronic pain could be something like reactive arthritis, which is a painful inflammatory condition that happens after infection. And so they had already started to look at whether we see in the serum of patients any sign that these patients might have had infections previously more commonly than maybe healthy people. And here's one example, and this is one that I did when I was there. It's pretty much the only that we've published, even only in abstract form. And you can see here, if you look at this is in bacterium, Chlamydia pneumonia. You can see here in a group of people with complex regional pain syndrome, not CRPS, but we found exactly the same things in fibromyalgia patients. So fibromyalgia was our other big group that we studied, CRPS and fibromyalgia. That there seemed to be, out of 92 patients, almost, well, half were highly positive for IgA, suggesting that they had recently must have had an infection. At least that's what you would conventionally say. But it wasn't zero in the healthy controls. There was always a sizable proportion of healthy controls who also had this. Yeah. Maybe interesting for scientists, but also maybe to show you, I was actually getting a bit desperate there. I was getting quite desperate because I really wanted to find out what's wrong, and there was something was clearly not right here. You can see that, but when you repeat this with, and we did this with sensitive tests, Yersinia, other bacteria, yeah, Yersinia, Campylobacter, Borrelia, then you could always see that people with fibromyalgia or CRPS and some of the other primary chronic pains, they were at that time called differently, but now they're primary chronic pains, were positive. And usually the proportion of patients that were positive were larger than healthy controls. But there was, on a singular patient, on an individual patient level, absolutely no pattern. I could not discern. These people didn't say, oh, yes, I had this infection. And they would have had to have multiple infections in order to make this true, because usually they weren't just positive to one, but to several of these. And so, well, that left me quite desperate to find an answer. We thought at this time, maybe is that because bacteria are still present causing this pain, maybe they're immune cells that are abnormal. And then we thought more about it. And eventually, in discussing it actually with my wife over prolonged beers in the evening, we thought that it could actually be that what we observed there may just show us that the body's regulation of the production of antibodies is not right. So what you measure in these tests are antibodies. Those are proteins, and I'll come in a moment to it, that are produced by the body to fight infection. And it looks like that somehow this is dysregulated in these patients. So rather than looking for an infectious agent, maybe we should have just seen this, and then we started to see this as an evidence there's something not right in how the immune system is regulated. And we thought then maybe in addition to what we can see there, which are antibodies against certain pathogens, certain bacteria, maybe there are also antibodies that by themselves are pathogenic, that are by themselves causing a problem by activating nerves in the wrong way. And perhaps we can examine this by a special way of doing an experiment called passive rodent transfer. And I'll show you in a moment what that means, yeah, and what we've done. And but before we go there, and I apologize to those of you who have seen this, I've shown this a number of times, but I think it's important that everyone has seen this to understand what we are on about here, because we are not on about inflammation. We're not on about the same kind of immune activation that you normally listen to or hear about when you think about rheumatoid arthritis or myasthenia or multiple sclerosis, for example. This is different now. This is about a special immune protein. They're called antibodies. And why do we all have antibodies? We all have antibodies in our blood, and we have them to fight infection. That's one important reason. So the red thing here is a bacterium. We don't want that bacterium in our body. So the APC, the antigen-presenting cell, will take up that bacterium and present it now to the sheriff and its deputy, the T and the B cells. This is called the adaptive immune system. You need those to effectively fight these infections. And the way to do it, and the way we are doing it, is we are getting activated by having this presentation here, yeah, that activates the T cells and the B cells, and they then produce many of these Y cell structures called antibodies. And the antibodies bind to the bacteria, and when they're bound, then they are basically dead. Yeah, they get immediately destroyed then by other immune cells. So how do the antibodies bind? They bind to certain structures which are very particular. So this antibody, even so from the outside, it looks like this antibody, doesn't it? It looks a bit bigger, but it looks like exactly the same. But it's not exactly the same, because this one binds to this structure, and it can only bind to this structure. It will only recognize this little part of the bacterium, and this antibody binds to this structure. And our body every moment has millions of these different types of structured antibodies that can bind to so many different types of structures. And so when a bacterium comes in, then some of these antibodies, some of these types will be augmented in the way that I've shown. So the binding then causes inflammation and destruction of the target cell, in this case, the bacterium. But unfortunately, this good system is accompanied by a failure system, or a system that can fail, and that is the production of autoantibodies. That means autos means self, so antibodies that instead of being directed to the bacterium, it's directed to ourselves. And that works like this. So if we have a kidney cell here, then every kidney cell will die. We are constantly renewing ourselves. All our cells die all the time. And when that happens, then the antigen presenting cell will come again. The same process happens, and it will present this dead element, this dead part of the cell, to the B cell and the T cell. However, in a well-functioning immune system, the B cell, T cell will be primed to not recognize this, to develop something called tolerance, so they won't act on this presentation. However, that kind of barrier, that kind of protection can break down, and that genetic predisposition plays a role, but also environmental damage. Even we know from some conditions, stress, extreme stress can play it there. And suddenly now, these cells will produce these antibodies. And you guess what happens? Unfortunately now, these antibodies bind to the healthy kidney cells, yeah, where they shouldn't really be binding. Otherwise, they should be prevented from binding then. But now the system is broken, and now you get inflammation and tissue damage in the healthy kidney cell, and that causes what we call autoimmune disease. Yeah, so you have an autoantibody-mediated autoimmune disease. Yeah, these are called autoantibodies. These are the proteins, and they mediate that. Now, the final step I want to show you, please, this is the final slide on this, is one more mental step, yeah, and that is that there are some rare autoimmune diseases which are not destructive, and they're already known before. They're very rare. For example, in neurology, there's one called neuromyotonia. And what happens in these conditions is that antibodies bind to voltage-gated to channels or receptors on the surface of cells. And for some reason, I think probably related to the structure of the larger part of the Y, these antibodies don't activate these destructive elements. So they just bind to channels or parts of the cell, and they still have an effect. They won't cause destruction, they won't cause inflammation, but they will change the way this cell functions. So you can see that here in neuromyotonia, normally when you have an action potential going through a nerve, so this is a nerve, then you might have seen there were potassium ions that after an action potential have to get out of the cell in order to stabilize the membrane. Yeah, that happens all the time in a motor, and this is now a motor nerve in neuromyotonia. When these antibodies bind, then the action potential comes through, but the antibodies have changed these channels. Can you see? So not all the potassium ions can get out. And that leads to a dysregulation of the motor nerve. And then patients actually experience this as spontaneous discharge, and they get involuntary muscle spasms. So my idea was, well, maybe something like that happens in pain. And maybe, you know, some of these antibodies bind to sensory nerves and just change the way these sensory nerves function. So that is the background to the study that I'm been invited to present. But I wanted to say that you might say, well, if that was the case, why don't we know about it? I mean, wouldn't we have long known about it? But actually, these antibodies cannot be detected by normal studies. So whenever you have these large studies that cost about 50 billion pounds or something, or 50 million, and they take 100,000 patients and try to find something out, they wouldn't be able to detect that, because proteomics, metabolomics, transcriptomics, which are these modern new approaches, won't show this. So potentially, it is possible that, although we've described this now in fibromyalgia and CRPS, that this could actually be something that causes also other problems, for example, fatigue disorders. I have no evidence that it does, but I want to say that there are other disorders where we don't know why they come about, and where patients mainly experience really difficult symptoms, but hardly anything can be measured. Yeah, so there's also that also exists in the gastrointestinal field, for example. So yeah, so this is a paper that we've published last year, and it's done together with David Anderson, Stuart Bevan in King's College, and Camilla Svensson in Karolinska, and with quite a number of mice. And David was the senior author for the whole paper. And this has had a huge impact so far, a huge attention for sure. It's now over 1,000 at this attention score, and has also been voted one of the top 10 science stories for 2021 by the Guardian Observer. And so what did we do? We took patients from Liverpool with severe fibromyalgia syndrome and enrolled them in a study, took blood, purified these antibodies. You can see here the Y-shaped structure, yeah? And then injected the antibodies to mice. So that was it. When I said we can maybe look at this in passive transfer, that means if there are functionally active antibodies in patients, then quite often you can detect the effect of such antibodies in mice. And why is that? Because the mice are not very different from us. We are not so different from mice, and many of the surface structures in the mouse cell is very similar to ours. And this approach works, for example, in other autoimmune diseases like such as myasthenia gravis, where you get weak muscles if you have that autoimmune disease. And if you take these antibodies from a patient with myasthenia and inject them to mice, then after a while the mouse will develop weak muscles, and you can measure that. Yeah. So I thought, well, maybe we can. So we thought maybe we can take these antibodies from patients. We had already demonstrated in complex regional pain syndrome that could potentially work. But we tried it now in fibromyalgia for a number of reasons. We chose that as our next subject and injected the antibodies to mice, and then did a number of measurements in the mice. So we tested for sensitivity of the pores, as many patients with fibromyalgia will get sensitive skin or muscles. We looked at how much they move. We looked how their nerves function. We looked at the innervation in the skin. You might recall that earlier this morning we heard that some patients also have a small fiber pathology. So their small fibers in the skin look slightly different. So we want to see whether we can reproduce these things. And we were able to do that. So all of our patients with, and I should say, we only include people with severe fibromyalgia, and there's no complete agreement international what that means. So ours all had pain intensity and fatigue intensity of 5 or higher. And on the fibromyalgia severity score in the impact questionnaire, they had a score of generally of 65 or higher. We didn't necessarily, so this is just because we recruited them all from our pain management program. And generally where I work, I mostly see people with severe fibromyalgia. So what I describe now, I can only say is valid for that group of severe fibromyalgia, which is probably about half of the group in most published databases, half of the total group. My bias is that similar mechanism also apply to the not so severe fibromyalgia, but I have no proof for that at this point. But anyway, all of these patients that we included from Liverpool were all testing positive in this assay, so they all were getting sore. And that was much more than we expected. I thought, oh, well, if we can have a small subgroup, maybe that would be brilliant because there might be treatment options, at least for that subgroup. However, all these patients tested positive. And then 3 pools recruited of serum pools from patients from Sweden also tested positive. Unlike in complex regional pain syndrome, where you can actually not transfer the symptoms unless you also injure the animal, which is interesting because in the patient complex regional pain syndrome, it's a post-traumatic condition after physical trauma to a limb, which is obviously not the case in fibromyalgia. So again, the antibodies that we found in CRPS before must be different from those in fibromyalgia. We don't know yet what exactly they are. All mice recovered eventually, suggesting that this process should be reversible in patients, as it is in most antibody-mediated autoimmune diseases. And then here is a few examples that we found. So if you can take a mouse here, I think this is probably a rat, isn't it? But anyway, that's the best picture I found. And you can ask, and the rodents will always try to grasp anything they can. And then you can measure how much grip strength they have. And you can see here that people with that mice injected with fibromyalgia IgG lose their grip strength. They get hyperalgesic, so you need much less. So this is threshold. So I'm not showing you now how we tested that, but you basically press the paw and see when the mouse says this is too much, it's getting painful now. And you can see that you need a much lower threshold, a much lower weight in order for the mouse to say, this is too much for me. Yeah, the healthy control injected mouse, you need 110 grams. Everyone will eventually withdraw their hand or paw. This happens to all of us. If Donald Trump presses your hand, you'll eventually withdraw it because it's just too much. But these mice withdraw it with very little pressure, as people with fibromyalgia would often do. And there's often, in many of the patients that we looked at, there's also a cold sensitivity. So when they won't leave their paw as long on a cold plate, because cold becomes painful much quicker than in the healthy control injected animals. And the technician who did this actually managed to look not just in the paw, but also in the thigh. So this was a widespread sensitivity all over the body. Then Camilla Svensson in her lab found that, and this was all done so far, what I've shown in David Anderson's lab together with Stuart Bevan. And then Camilla Svensson and Karolinska also found that when she injected these IgGs to mice and observed how much they would move around, and the mice move in the nighttime, not in the daytime. And you can see here, initially it seems to be okay, there's no difference. They move more, all of the mice move more, but then there's a clear separation here, and the healthy control mice move, at the peak times as they would normally do, and this is depressed in the people with fibromyalgia, suggesting that, our patients told us that looks like my fatigue that I developed. So I'm okay for a while, and then I sort of can't do it anymore. But we don't know what this is due to, but it's certainly a behavior that you would say as a behavior also in patient, yeah. Okay, and then there's also, you can see that with the naked eye, there's a slightly less, the green is nerves in the skin, so there's a slight pathology there of the nerve fibers. So we see that in about 50% of patients, as Ernest has said this morning, and that we could see that in the mice. So we even managed, and that's done in Camilla's lab, to show where these antibodies might bind. And she found that they don't bind to the brain or spinal cord, but they bind certainly to several peripheral tissues, and certainly to a tissue that's very interesting called the dorsal root ganglion. So this is your vertebral body. This is a spinal cord, and there's these little ganglia, which is where all the cell bodies are from all the peripheral sensory nerves, and that's where they bind to. And Emerson Kroc managed to show that you can get cadaveric dorsal root ganglia. So we found that first in the transferred animals. So if you then look at the after the animals become so sensitive, the mice get sacrificed, you look everywhere in the tissues, and then you find that there is binding of the human IgG to the mouse dorsal root ganglia, to these mouse structures. But in order to confirm whether this also holds true for human tissue, one can get, people do donate their tissue to tissue banks after their death, and you can get in that way also dorsal root ganglia. And Emerson Kroc and Camilla Svensson's lab used these, sliced them up, and all the white that you can see here is the IgG from patients which binds, whereas in healthy controls there's very little binding. So there's binding, and what does that mean? If the IgG would bind to dorsal root ganglia, it would mean exactly what we had hypothesized, that maybe certainly that is a tissue where the binding could change the function of the cells there, and could change the way the nerves now process signals, and that could lead to an augmentation. And if that happens constantly, then surely there will be a wind up in the spinal cord and in the brain. So we think that we've discovered here maybe one of the root causes, maybe the root cause of how this pain could be generated in these patients through an autoimmune reaction. So how does that translate to the treatments in the future? So one can already reduce antibodies in the blood, and one can do that with plasma exchange or immune absorption. And this is just 2 or 3 slides, and then my talk will be finished. You can take blood from a patient and separate the blood cells and remove the antibodies and replace it with fluid, and that is one way of doing it. And you can see that actually this is very effective. You can reduce the antibody level of any antibody by almost 90%. And that works in other antibody-mediated autoimmune conditions. So we've written an application now to the MRC to do that kind of trial to see whether that works. And then there's a new drug, but there's other drugs as well. This is just one that I'm interested in because they don't have many side effects and are quite elegant. And again, they have just been developed. So the first of these drugs has just gotten their license. And the way it works is that all autoantibodies in the body, all antibodies always currently are taken up by the cell in all of us, not just in fibromyalgia, in healthy people. They're taken up and they're getting constantly broken down. So the cell then lyses this, and this is just what happens to all our proteins. It's nothing specific. We constantly break down all our proteins. There's a constant recycling process. And this little flower pot there protects antibodies against the lysis. And is that good or bad? It's bad for us because we actually want to get rid of these antibodies. So this little flower pot is not so good, and if we could sort of make it defunct, could stop its action, then much more of these antibodies would be broken down. And industry has indeed now developed a drug that can do that. And I am hoping that maybe that is one of the trials that will be done to help fibromyalgia patients. So I'd like to say, sorry, I forgot, I want to say this. How does distress relate to the onset of fibromyalgia symptoms? And I feel that, please, let's not think that this is completely in isolation, what I've shown you there. So I think that does fit very well in the biopsychosocial model. And so far, the idea has been that distress will lead to symptoms eventually. I don't know what I said there. Let's just see. So I can't remember because I have this funny, yeah, okay. So maybe in vulnerable people, genetically or psychologically vulnerable people. And that's the traditional idea how distress leads to symptoms. In fibromyalgia, there is really evidence that people that have experienced large, trauma and psychological trauma are at higher risk for fibromyalgia. And the original idea then is that this could be something that has to do with a way that the brain now does this. And this actually the concept of hysteria, really, that the brain somehow now processes the distress experience in a funny way and uncomfortable way, but it's still the distress that the brain just can't really express, and it expresses its symptoms. But what we are saying now with the antibodies is that distress might actually cause the body to produce these antibodies, which then leads to symptoms. So the concept of hysteria could be then thrown out of the window. So in summary, so recent research findings have shown that non-inflammatory functional autoantibodies may be responsible for symptoms in severe fibromyalgia. We can maybe prevent this or interfere with the production of these antibodies, and that might be a promising approach for treatment of severe fibromyalgia. And these are some methods that one can use. And I think this is more for clinicians. I think we need prolonged treatment. It's more like when you treat refractory myasthenia gravis, you don't see the full effect, I think, if you just treat for 4 weeks. We've tried a little bit of that, and it seems to work quite well, but I think one has to do the trials. One wonders really whether these autoantibodies form a regulatory system that have so far been overlooked and which could also be important in other conditions. And we would love to know what are the molecular mechanisms translating the experience of distress. Not every patient gets this after distress, that's for sure, but some do, I think. So in those patients, how does it actually work? And could maybe in the future be some sort of trauma-focused therapies improve their situation, and you don't even need to give drugs then. But currently our methods don't do that. So psychological therapy generally cannot cure that condition. Okay, that's it. Thanks very much.